Welcome to the Cholesterol Wars, Navigating a Shifting Battlefield, a joint continuing medical education program brought to you by the North American Thrombosis Forum and CNCS-CME. Statin therapy is the recommended treatment for lowering low-density lipoprotein cholesterol, LDL-C, and reducing atherosclerotic cardiovascular disease, ASCVD risk. However, evidence-based and guideline-recommended therapies, including ezetimibe and PCSK9 inhibitors, continue to be underutilized, even among the highest risk patients. Consequently, an unmitigated burden of cardiovascular risk persists. More education is urgently needed to address this problem, and to that end, NATF invites you to join us for a virtual series of webinars that discuss some of these key issues in cholesterol management. You are watching part 4 of this series, Current Treatments for LDL-C Lowering and Why Patient Access is Important. This program is designed for physicians, pharmacists, nurse practitioners, physician assistants, nurses, and allied healthcare professionals in the fields of internal medicine, primary care, family medicine, hospital medicine, cardiology, and endocrinology. The learning objectives for this module are listed here.
Hello, everyone. My name is Jorge Plutsky. I'm the Director of Preventive Cardiology at the Brigham and Women's Hospital, and I'm pleased to welcome you to the North American Thrombosis Forum's CME webinar series, The Cholesterol Wars, Navigating a Shifting Battlefield, Current Treatment Strategies for LDL Lowering and Why Patient Access is Important. We have a terrific faculty today, and I appreciate you taking time to join us. I'm sure you're going to enjoy the program and get a lot out of it. So the North American Thrombosis Forum is a nonprofit organization dedicated to improving the lives of those affected by blood clots and related diseases through comprehensive resources and innovative programming. NATF strives to educate patients and healthcare providers about thrombosis and its complications. This program was supported by an education grant from Amgen. We have disclosures of our financial relationships, which are available in terms of myself. One of the things that I will say comes up in general about why a thrombosis forum would be engaging in these issues. And I think there are many reasons for that. We know that there is a relationship between atherosclerosis, cardiovascular risk, cholesterol, and the prothrombotic nature of those issues. There's a convergence of pathways related to it. And I think that as NATF exemplifies, there's a real commitment to trying to improve approaches to management of patients, and that spans all aspects of atherosclerosis and its complications. So certainly makes great sense to me, and I'm glad we're able to call on NATF to help us with tackling these issues. And to educate us and engage with us around this discussion, we have really a fantastic faculty today, and both Heather Johnson and Seth Martin, who are colleagues and great educators, and I'm looking forward to their presentations. We're going to start with Heather. I'll introduce her, and then we'll transition to Seth. So Heather Johnson is a preventive cardiologist at the Christine E. Lynn Women's Health and Wellness Institute of Baptist Health, South Florida, and clinical affiliate associate professor of medicine at the Charles E. Schmidt College of Medicine at Florida Atlantic University. Dr. Johnson's well recognized as a leader in population health heart disease prevention and women's health, and is an active member of the American Heart Association, the American College of Cardiology, and the American Society of Preventive Cardiology. And Heather, we really appreciate your being here and are very much looking forward to your presentation.
Thank you so much, Jorge. I greatly appreciate it. And so over the next few minutes, we'll be talking a bit as far as 3 key objectives. My disclosures are here as listed. I will not be discussing any non-FDA approved indications. And our objectives over this time is really to highlight what are some of the recommendations as far as achieving optimal LDL levels in our highest risk patients as far as those with atherosclerotic disease, ASCVD. We'll also highlight some important barriers and how to also understand the negative impacts as far as limited patient access in relationship to some of these tools, some of these therapies in LDL lowering. And so first, I would actually like to start off with the definition when we define our ASCVD population. In the most recent cholesterol guidelines, as far as secondary prevention, as far as who already have ASCVD, very quickly there was the separation as far as defining high risk and very high risk. And so the very high risk is if there are multiple clinical ASCVD events, as we see in the peach box on the left, or you could have one of those events or procedures in addition to multiple high-risk conditions. Now, these high-risk conditions are very common: age greater than 65, presence of diabetes, hypertension. So for me personally, and I'm sure for many of you, you're seeing very high-risk ASCVD patients. Now, of course, in addition to a healthy lifestyle, the number one step along both pathways, high risk and very high risk, focused on high-intensity statin therapy. This has been one of the mainstays in our toolbox, and we'll discuss a lot more. However, when we talk about how well we have done in just high-intensity statin therapy, just as one particular treatment possibility, some pharmacologic data have demonstrated as far as over 600,000 patients with atherosclerotic disease, cardiovascular, cerebrovascular, peripheral artery disease. Starting in 2019 and moving forward over a year, they just wanted to see who was receiving high-intensity statins as far as guideline concordance, and this was published earlier this year. What was demonstrated is that almost half here, almost exactly half in the pie chart, half of the individuals were not receiving any statin. Remember, it's one of our foundations, and less than 25% were receiving high-intensity statins. As far as who was less likely to receive high-intensity statin therapies, females over the age of 45, having cerebral or peripheral artery disease and higher comorbidity index, and it was about 47% women in this study. But an interesting point is that once patients were prescribed high-intensity statin therapy, that particular group, the high-intensity group, had the highest adherence rates as far as proportion of days covered, as outlined below. Now, the Gould registry in the United States, again, looked at this high-risk population, ASCVD. And there, it was a registry that's focused on as far as receiving any lipid-lowering therapy, with the primary outcome being any change in lipid therapy over 2 years. So not very complex, basically looking at this therapeutic inertia. Over 5,000 individuals, 40% women, and there was a group of just who's on PCSK9 inhibitors, which we'll talk about a bit more, and then also whose LDL was over 100 versus less than 100 as they enter the registry. So at baseline, as we see in the figure, we see as far as over 80% or around 80% being on any statin between baseline year 1 and sort of the medium blue, and the lightest blue is year 2. But if you notice as far as high-intensity statin use, again, one of the baselines as far as therapeutic options, less than 50%. Now we're looking at other treatments as far as ezetimibe and statin combination, PCSK9 inhibitors, very low numbers. And in fact, the intensive lipid-lowering therapy columns represent the combination of these. So we were not doing very well as far as what was going on as far as entering or throughout the 2 years. The Gould Registry also looked at who could achieve an LDL of less than 70 versus less than 55. And I know the less than 55 discussion is a bit new, and we're going to address it quite a bit moving forward through this talk here. But what was interesting is that if they were taking PCSK9 inhibitors as far as baseline in year 2, yes, more likely as far as achieving an LDL of less than 70 or less than 55, but again, a small percentage of individuals. In fact, remember the primary outcome was any change. Did we change anything as far as lipid-lowering therapy? Well, only 17% had a change as far as intensification, and that was increasing a statin, and we'll talk about some limitations of that. 10% had de-escalation, that was discontinuing statin therapy. So over 2 years, the majority of the population really had ongoing, uncontrolled LDL cholesterol in high-risk populations. So there was a discussion that talked about just guideline concordant statin therapy. What are some of our barriers? Remember, this is our secondary prevention group, our highest risk group. And there were three key drivers. Number one, therapeutic inertia. What is happening as far as the initiation, starting the prescriptions, what's going on as far as actually prescribing the medication on that clinical side. As far as the patient side, yes, statin-associated side effects, and we'll talk about that. But then also remember, our patients are receiving so much external information. And of course, we talk about the internet, the media, neighbors, friends, family members, and really helping them understand what their own personal diagnosis is and why the recommendations are being made. We have to highlight that women are also less likely to receive guideline concordant care, and we'll talk about some of the more of that data shortly. So some of the solutions talked about as far as how do we improve really understanding and disseminating guidelines, similar to webinars like this. I really like to emphasize team-based care. Many times there may not be a pharmacist available right there in the office, but when I meet a patient, I ask them, well, who's your primary physician? Do you see an endocrinologist? Who is a part of your healthcare team overall? How do we stay in communication? In addition, clinical decision support tools, and of course, helping patients understand and receive trusted information. Now, the PALM registry has highlighted important differences as far as in statin therapy among women. High-risk women, women with ASCVD. This registry looks at both primary care, endocrinology, and cardiology practices. Well, women were less likely to be offered a statin, remember, high-risk population, but also more likely to decline a statin or discontinue a statin, with women being more likely to have side effects from high-intensity statin doses. So we're beginning to see a pattern as far as barriers to just trying to focus on just high-intensity statin use. Women were also less likely as far as being willing to try another statin. We have to highlight that female is one of the risk factors as far as contributors to statin intolerance, with various studies highlighting differences in physiology, but also understanding, as the boxes show, multiple comorbidities, vitamin D deficiency, also hypokalemia, untreated thyroid, frailty play a role. When we talk about statin intolerance, it's adverse effects to at least as far as trials of 2 statins. But when we talk about adverse effects, what patients report matter. It is their reported side effects, in addition to lab findings or things that we may notice in relationship to assessing and evaluating it. But even outside of those labs, that patient-reported symptoms is key. Now, the nocebo effect, you may have discussions of a patient who says, I know I am going to have side effects if you put me on this. It's anticipating harmful effects, which of course can play a role in statin intolerance. I also want to highlight that there can be partial or complete intolerance. Partial meaning that the patient may tolerate lower doses, ultra dosing, every other day dosing, but you still can't get them to the maximum needed dose of a statin therapy, and complete intolerance meaning they can't tolerate any of it. So there has been a lot of focus as far as introducing other therapies earlier, either in combination with or an alternative to statin therapy in these high-risk populations, and we're going to discuss this a bit further as far as the various pathways. The European Society earlier this year, in fact, recommended as first-line therapy to use combination lipid-lowering therapy, and they have similar as far as very high risk versus extremely high risk. But notice even in their extremely high risk, they're looking at triple therapy, statin, ezetimibe, PCSK9 inhibitors. But I also highlighted we do have other products on the market here, and we'll talk about it in a second. But their goal, at least a 50% LDL reduction and the LDL of less than 55, is important, and we'll talk about that goal again. We also realized that the earlier that we introduce combination or alternative therapy to those who cannot be on maximum tolerated statin therapy or achieve the goal is key. Because the longer those higher LDL levels are around, the greater the progression and the rate of progression in relationship to atherosclerotic disease. So just recently, the 2022 ACC Expert Consensus Report came out as far as non-statin discussions, non-statin therapy in order to achieve the optimal goal. Notice it's an LDL reduction of 50% and an LDL cholesterol of less than 55. If possible, a maximally tolerated statin. But as we talked about, there are multiple barriers to that. And so there has been quite a focus on how do we get these other components in our toolbox on board a bit sooner. This talk will not focus on FH as far as in my particular aspect, but we'll bring that up in discussion later. So when we talk about lowering LDL, we're very familiar with the statins on the left side. Down below in the far left corner, there's ezetimibe, which really focuses on reducing cholesterol absorption as far as both dietary and biliary cholesterol. As far as ezetimibe, one of the trials was the Improve It trial that looked at the addition of ezetimibe to maximum tolerated therapy in a high-risk group as far as recent acute coronary syndrome. Baseline LDLs varied whether or not there were statins on board already, but a significant reduction in LDL is able to be on high-intensity statin, with overall about a 6% reduction in composite endpoints of major adverse events. There were some variability in significant and non-significant findings for individual outcomes, but overall a 6% reduction with the number needed to treat of about 50. Now, when we talk about PCSK9 inhibitors, which are now a very important core component of our treatment, their role when we talk about just the PCSK9 enzyme, what it is doing, you see in the top panel as far as the little blue symbol, the PCSK9 enzyme, it actually promotes the degradation of the LDL receptor. So the LDL receptors get degraded, they are not recycled, and therefore there are fewer LDL receptors as far as managing or processing the LDL cholesterol. The goal with the PCSK9 inhibitors, which are human monoclonal antibodies, are to be able to allow to basically bind that PCSK9, which allows the LDL receptors to be recycled. Now, this is some outcome data, which is extremely important and really drives our use as far as PCSK9 inhibitors for both approved PCSK9 inhibitors in the U.S. Notice the large sample size, very high-risk population, including when we look at elevated LDL, non-HDL, or ApoB at times, but then also important outcome reduction in cardiovascular events. So when we talk about our selection, we're also focusing on reduction in cardiovascular events in this high-risk population. Now, in addition, we have newer agents on the market. Notice in the left side at the top, bempedoic acid, which really focuses on decreasing the biosynthesis of cholesterol. And so therefore, there's a greater availability of LDL receptors to address circulating LDL. Now, bempedoic acid was approved by the FDA as far as individuals that are statin intolerant and or on maximally tolerated statin already. What's unique about bempedoic acid is that, yes, it works upstream to statins, but it also avoids active metabolites in the skeletal muscle. And so therefore, the active form does not occur until it actually gets to the liver. It's a prodrug and then converts to the active form in the liver. Now, what was demonstrated is that you have LDL reduction with ezetimibe by itself, bempedoic acid by itself, but the greatest reduction is the combination of bempedoic acid and ezetimibe. Bempedoic acid is available by itself or in combination with ezetimibe. We're waiting for additional cardiovascular outcome data, though. And most recently, as far as the mechanisms that's available now with FDA approval, is inclisiran. Now, inclisiran is an injectable, and after the loading injections, it's every 6 months. It is very specific as far as targeting hepatocytes. And once as far as integrated, it's in endosomes that allow it to slowly release, and thus every 6 months for maintenance. Now, inclisiran is when we talk about how it works, it actually decreases the synthesis of PCSK9 enzymes. So again, a little bit more upstream. So it actually decreases the synthesis of PCSK9 enzyme using small interfering RNA. And so therefore, a different mechanism, an injectable medication. There are key trials going on in the US and internationally as far as Orion 10 and 11. Notice some important exclusion criteria when you start thinking about your high-risk ASCVD population. But the major focus has been how it actually drops circulating PCSK9 enzymes. And so that's how the LDL reduction focus is actual percentage and absolute change. We see the blue line here with inclisiran versus placebo in dropping the PCSK9 enzyme. And therefore, with inclisiran, we're looking at about a 50% reduction in LDL, but again, awaiting some outcome data. So in general, our tool chest is expanding. Ezetimibe and PCSK9 inhibitors, we have outcome data, both oral and injectable options, and with newer both oral and injectable options with bempedoic acid and inclisiran. You can see that beyond ezetimibe, PCSK9 inhibitors tend to give a significance as far as LDL reduction with cardiovascular outcome data. Some of the adverse effects are there, and we're also waiting to hear about inclisiran. I do want to highlight that in spite of our expanding tool chest, each of us are aware as far as the barriers of moving from guidelines to actual clinical application based upon some barriers as far as insurance formulary. This was a study that really focused on access, and we are used to doing our prior authorizations. We'll talk about it a little bit in a second. And we go through, and there may be a rejection on the prior authorization. It's not approved. Some common factors, maybe a discrepancy as far as what diagnosis we put versus what the payer wants as far as covered diagnoses. Maybe documentation, coding, some barriers there. But what's important is that rejection in prior authorization and looking at large amounts of data as far as over millions of patients with ASCVD or also FH, familial hypercholesterolemia, high-risk populations, is associated with worsened cardiovascular outcomes. Now, there's a second part of this is that we go through prior authorizations, we get it approved, the prescription is ready, and the patient doesn't pick it up. Unfortunately, it may be also cost, in addition to some other patient factors, but cost tends to be more common, and that's called abandonment or abandoned. The prescription is approved, it becomes available, but it's abandoned. Many times you may hear a patient say, I got to the counter and they told me how much it was going to be. And it was just cost prohibitive. Unfortunately, that is also associated with worse clinical outcomes. So we're going to talk about how to improve patient access. So 3 key points for me: ASCVD population, extremely high risk and very high risk, however we defined it, as far as unfortunately many having suboptimal LDL cholesterol levels. Not just as baseline. We're not talking about just around the event, but moving forward over years. We're not getting them to where they need to be. LDL reduction at least 50% with an LDL of less than 55. There are multiple barriers we still need to address, and we're working hard within our clinical setting to really tackle them. But we also have to understand that improving access at the counter is a key factor, and that unfortunately, many of these barriers throughout can worsen clinical outcomes in this high-risk group. Thank you so much.
Thanks, Heather. That was terrific. You've heard a lot of overview talks about lipid management and prevention, but That was, very well presented and much appreciated. And I'm looking forward to our discussion. And before we get to that, we're going to place context around the data that Heather laid out so nicely now by moving on to a real-world patient case presented by my friend and colleague, Seth Martin. He's an associate professor in the Division of Cardiology at Johns Hopkins University School of Medicine. He's a core faculty member of the Ciccarone Center for the Prevention of Cardiovascular Disease, where he directs the Advanced Lipid Disorders Program in the Digital Health Innovations Lab. Dr. Martin has also led the development of an improved LDL cholesterol algorithm that's been clinically adopted around the world in professional guidelines and practice. And so, Seth, we appreciate your joining us and look forward to the case and then the discussion to follow.
Jorge, thank you so much. It's a pleasure to be here for this important discussion. Thanks to the whole organizing committee and the NATF for bringing forth this important dialogue. And that I agree, that was just a terrific presentation by Heather. So I hope that I can reinforce some of the critical concepts that were already so beautifully described. These are my disclosures. Similar to Heather, there's not going to be any discussion of non-FDA approved indications. So the learning objectives are to compare available treatment options for LDL lowering, to discuss clinician-patient barriers to initiating LDL lowering therapies, and describe methods to optimize patient access to LDL lowering therapies. So here is the case that we're going to focus in on, case of TA, someone who I've had the pleasure of caring for both inpatient and outpatient. So when I met her, she was a 48-year-old African-American woman with a history of MI, status post single vessel PCI 5 years previously. And so I met her during this hospitalization that she had and then followed up with her outpatient. So during this hospitalization, she had a type 1 STEMI and was unfortunately found to have progression of her coronary artery disease and now required bypass surgery. And so now, after caring for her during that hospitalization and making a new diagnosis related to her lipid disorder that we're going to get into, I'm now following up with her in clinic. So more about her lipid disorder, her lipid profile. So we see her untreated lipid profile shows a strikingly high total cholesterol, which is explained by her high LDL cholesterol level of 307 milligrams per deciliter. She also does have multiple other risk factors, as you see here, including diabetes, hypertension, and rheumatoid arthritis. Her family history was quite notable. So a father who had an MI at age 57 and hyperlipidemia, a brother who died from an MI at age 50, also with hyperlipidemia, and then a paternal uncle with a similar situation. And so this striking LDL level with this family history and her own personal premature coronary artery disease is certainly pointing at a diagnosis, but a diagnosis that had not been made in the multiple decades prior. So I'm going to get to that on the next slide, but I hope I'm prompting you to think of something quite important. Her physical exam was notable for corneal arcus and thickened Achilles tendons, reinforcing this diagnosis of familial hypercholesterolemia. So there's multiple clinical criteria out there, the Dutch and other types of measures. I wanted to just focus in on one that's gained a lot of traction, the American Heart Association criteria for diagnosing familial hypercholesterolemia. So there's clinical criteria as shown in the left-hand column, and then there's also genetic criteria. Increasingly, genetic testing is used to look for mutations in LDL receptor predominantly, but also ApoB, PCSK9. So when there is a lipid profile with a high LDL and a genetic defect that's identified, we can confirm a genetic diagnosis of FH. However, even without that, in a case like I've presented, the diagnosis is very clear based on clinical grounds. So in her case, having an LDL well above 190 for adults, along with having similarly affected first-degree relatives, her own premature CAD, that's enough grounds to make a clinical diagnosis of heterozygous FH. Patients with homozygous FH who are not focusing on today have LDL levels much higher, above 400. So I really want to emphasize FH because it's severely underdiagnosed and undertreated. The prevalence is estimated about 1 in 250 in the US. It used to be that about 1 in 10 were diagnosed, and the more recent data are encouraging thanks to the efforts of collaboration around the country and leadership from the FH Foundation. It now appears that it's up to 3 in 10, but still most patients are not diagnosed. So we have a long way to go. This is an autosomal dominant condition, so passed on with a 50% chance from a parent to a child. There's a 20-fold increased CVD risk when someone's genetically positive with FH with a high LDL level compared to normal people. And this clearly accelerates CHD risk. And if we're looking at, in particular, a young person, as shown in data out of Boston, who has a family history and has a high LDL in the setting of a young person having an MI, it's very likely 6 in 10 that they have FH. But then, unfortunately, statins and treatment are underused, and these patients end up having poor outcomes. So we have a long way to go here. I mentioned the physical exam findings in the case. So these are some photos from my clinic of patients that have had the various physical exam findings. We see ARCUS here. We see xanthelasma, which is less specific for FH. By the way, the corneal ARCUS at a younger age, less than 45, is really quite specific for FH. And then there's the deposition in extensor tendons. So here we see them in the hands and then in the Achilles tendon, the thickening of the Achilles tendon, and it even can be bulging out. So those were part of the diagnosis in our case, along with the lipid profile, the premature disease, the family history. And so from a treatment standpoint, she is now taking the atorvastatin 80 milligrams per day, as well as ezetimibe 10 milligrams per day, participated in cardiac rehab, which is really fantastic because that's often underutilized as well. And now she's following up in clinic. And so this is what her lipid profile looks like. So we've gone down from an LDL in the 300s down to an LDL of 127. The question being, what is the next step? And so as Dr. Johnson beautifully covered, we look to the guidelines, and based on the 2018 guidelines, there's this category of very high risk in patients with clinical ASCVD. So if we follow that flow chart where she's already on the high intensity statin therapy, she's already on ezetimibe, it then leads us to consider as a class 2A recommendation a PCSK9 inhibitor in a patient who has an LDL 70 or more and a non-HDL of 100 or more. Very high risk includes having a history of multiple ASCVD events or one ASCVD event plus multiple high-risk conditions. So the patient presented really meets very high-risk criteria in multiple ways. So in terms of major ASCVD events, these can include recent ACS, so within the last year, a history of MI other than the recent ACS. So she's already met criteria based on these two. There could also be a history of ischemic stroke or symptomatic PAD with claudication with an ABI that's low or previous revasc or amputation. If our patient had had only one of these ASCVD events, then there can also be the criterion can be met by having multiple of these high-risk conditions. So older age, heterozygous FH, which she had, diabetes and hypertension. And you see these factors that really are very common clinical factors that we see in many of our patients. So if your patient doesn't have multiple ASCVD events, then but has one, we can look to these factors to meet those very high-risk criteria. So it's quite clear that a PCSK9 inhibitor is indicated as a next step, but I wanted to just take a moment to highlight this article around shared decision-making that I had the honor to work on with Dr. Neil Stone and others, and really highlights that even if the medication is indicated, it's important to engage in this back and forth dialogue with the patient to strengthen the relationship, to increase their engagement and medication adherence as they become involved in the decision and really understand and buy into the initiation of an additional medication. This can really heighten patient satisfaction and acknowledge that although the recommendation is there, their case is unique, and we need to take into account their preference. And this is a nice Chinese proverb that really speaks to the importance of involving the patient in their decision. So one thing that I wanted to just also note is that she had her LDL assessed by our lab, which uses a more contemporary LDL equation. This is a paper that collaborated on with Dr. Ty Gluckman. It was led by Aparna Sajja, a trainee who's now a cardiology fellow. And what we showed is that if one uses the Friedewald equation, so all the individuals in this chart have a Friedewald LDL level less than 70, and they're patients with ASCVD. And the folks that are shown in blue are patients who have LDL levels that are consistently less than 70, regardless of which equation you use to calculate LDL. Those that are shown in orange are those that have an LDL level that's 70 or more if you use a new equation called the Sampson equation out of the NIH, or you use the method that we developed at Hopkins. And then those shown in gray are those that are less than 70 by both the Sampson and Friedewald equation, but are still 70 or more by our method. And we see that those with triglycerides of 150 or more, this discordance is even more prevalent. And so these are patients who, if we were to use a calculation that's underestimating LDL, they would be deemed to have had their LDL levels controlled and no longer be candidates for therapy. So this underestimation can lead to undertreatment, which is really concerning in a setting where there's already severe undertreatment of FH patients and ASCVD patients. So we at our lab now use the equation we developed. Quest Diagnostics has adopted it. And I just bring this up for clinicians to be aware of which equation is being used by your lab, and to consider that if it is possibly being underestimated, to look for recalculation. We've put out a free smartphone app that allows one to calculate it by our equation if the lab hasn't adopted already. So Dr. Johnson brought up access, and I wanted to highlight this NLA paper as a resource, this checklist for PCSK9 approval. So this is something that in our lipid clinics that deal with PCSK9s all the time, we've really become accustomed to making sure we have the appropriate documentation to support insurance approval. So we don't have to go through all the details of this, but at a high level, the key categories to hit are having indication really clearly listed, whether that's ASCVD or FH, to have a recent lipid panel within the last month, having documentation around the diagnosis of FH, which is why we really emphasize that. Statin history, what they've tried and failed in the past, clear documentation around where we're trying to get their LDL, and then documentation around adjunctive therapy like ezetimibe. So document. Most of the approvals are going through on the first time, but if there is a need to appeal it, definitely appeal. Don't give up. And so that's the key message: document, and don't give up. So in the case of TA, her untreated LDL has come down all the way from the 300s down to 49 with the addition of evolocumab on top of atorva and ezetimibe. So with this triple therapy, she's done really well, even by the new non-statin consensus pathway that Dr. Johnson mentioned. She's come down below 55. But we did want to acknowledge that had she not had that type of success with that 3-drug regimen, there are new options like those that were mentioned by Dr. Johnson. So that brings me to the key points. No FH, look for FH, find it, treat it. Very high risk is defined by multiple ASCVD events or one event and having multiple high-risk conditions like hypertension, diabetes, and other common conditions. There's this LDL threshold of 70 from the 2018 guidelines, and now there's this introduction of a goal of less than 55 in the latest expert guidance. And then recognizing Friedwald underestimation and recalculating LDL. So knowing the method your lab uses and being clear about the potential for underestimation if they're still using an older method. And then when it comes to patient access, document, 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 and don't give up. So thank you, Dr. Plutsky, and I'm looking forward to the discussion.
Great, terrific. Another excellent presentation, and really just as good as they come in terms of thinking about the cutting edge of these issues and ways in which we can improve care. I'll look at it. There's Heather's back, and I'd love to address some of the questions that have come in, and also pick your brains about these issues. Let me begin with one broad one that we've gotten a few inputs on and that we know is a real operative issue, which is, how do we overcome that clinical inertia? I mean, it is amazing that the cholesterol story, with FH and then with more general forms of hypercholesterolemia, really it stands among the great success stories of the modern era of medicine, between the genetics of FH and the therapies that came along, and then the impact they've had on events. And so it's incredible to see patients not receiving the benefit from that. But as Heather showed and Seth, you highlighted, we just don't see these opportunities being used. So I'm curious about what you both think would be, perhaps the central strategy about trying to get not the folks who are who already are believers and converted, and we know we have challenges that the people who listen to these kinds of programs are, good examples of preaching to the choir, but really, how do we system-wide really move the needle on treatment? And as your case highlighted, Seth, earlier treatment in that case, I'd love to hear your thoughts. Heather, let me start with you about addressing clinical inertia within a system or within practice.
Right. No, thank you. And Seth, outstanding talk. I really love the key points, truly. Outstanding case, excellent. And you're right, FH under-recognized, undertreated. And that's what we like to see. We like to see as far as really getting to that goal and that team approach. So whenever I personally meet with someone, as far as, even if it's primary or secondary, we're talking about secondary high-risk population today, we actually start off just reviewing their history. So it's a new visit. I get a little extra time here with new patients, and it's really a discussion of their own personal story. What defines them as far as, secondary prevention. But I share the discussion of, and I tell them, and I say this every time, you have heart disease or you have had a heart attack. What is our goal? Our goal is to prevent, whatever the event may be, it's what is their own personal diagnosis? And we break it down just that simply. And it's a reminder. And sometimes when they're bringing in outside records, we're meeting for the first time, their eyes open up of, this is personal to me. I really do have that. It's beyond having a stent placed. It's beyond being admitted or discharged. It is, I have heart disease. The second part of it is that I also talk about it being a journey, and that it will take, for most people, as far as multiple steps to get to where we need to be. And to help as far as addressing inertia, because multiple other things come up, and, oh yes, I have palpitations and this and that. Part of what I do is even write down, okay, this is the step we made today for the cholesterol, et cetera. Pending these labs, this will be our next step or our next discussion. So they're already looking ahead and understanding it. And it also helps to hold me accountable of, we said we were going to focus on that. The other part, and I saw in part of the Q&A, is that sometimes the discussion is the first part, and as Seth, you pointed out, that shared decision-making. And the patient may not be ready for that next step, an injectable or something like that. So I'm writing it down, this is some information, take some time to read about it. And we have the appointment set up to discuss X as far as whatever that may be, PCSK9 inhibitor injectable. But again, it's them understanding the process that I want them to understand and what their personal needs are. And so the inertia really does play a key role, but we've tried to find ways, because as highlighted, pharmacists, nurse practitioners, additional staff may not be there to support that lone clinician. And so how do we make sure that there's a team approach to get to the next level? And I have some patients who said, thank you, Dr. Johnson, for listening and being aware that I'm just not ready. But then how do we begin to address those issues to help get them to that point? So it is time. But at the same time, we also then set up what's going to be our follow-up plan to move the needle to that next step.
Yeah, I think those are excellent points. I often, think where there may not be team resources, it becomes really important the extent to which the primary caregiver, whether it's a PCP or you're seeing a cardiologist, really communicates the advantage and benefit for the patient, and does it with conviction and with passion, while still being attentive to what the patient is bringing to those kind of scenarios. I think one of the eye-opening things for me is someone had pointed out to me when I was giving one of these talks, although not as good as either one of you, the comment I got from a psychologist happened to be on the panel was, oh, I see you're a fan of motivational interviewing. And I said, well, I have no idea what that is. And that's because I went to med school too long ago. And so it sent me to looking that up. And it was really eye-opening to see that whole field and simple notions about avoiding paternalism and talking to a patient, you must do this. And sort of recognizing that no patient comes into these discussions seeking harm. No one's avoiding a statin because they want to have a heart attack, or they're saying, boy, I'd love to have a stent placed or have bypass surgery or die from a heart attack. And so trying to understand what the barrier is, I think, is critically important. Seth, I'm going to put a different spin on another question that comes up. We're often encountering, as in your case, patients who are, not going to get close to goal when adding ezetimibe to a statin, and that one could say, okay, well, you're further than 15 to 20% from your LDL goal, and we should move on to PCSK9. In terms of conversations with patients, do you, how do you see that in terms of bypassing ezetimibe and when you need even further LDL reduction, or are the payer approval pathway is going to force you to have to go through that ezetimibe step?
Yeah, I'm glad you brought this up. This is a key topic that comes up all the time. The ACC, the latest 2022 ACC consensus pathway, really was helpful in kind of addressing this head on. And so it says that if you really need more than a 25% LDL reduction, you can consider going straight to the PCSK9 inhibitor. And I think that reflects the way that many of us have been thinking about this in clinical practice. It was always a bit funny to sort of think, well, okay, my patient they're really quite high risk and they have an LDL that's approaching 70. They need another agent, but they have an LDL below, between 70 and 100. And if I start the ezetimibe, they may, especially if they're closer to that 70 mark, now they're going to bump under that 70 threshold, and then they're going to no longer qualify for the PCSK9. But we're basically getting kind of 1/3 of the efficacy with a 20% instead of 60% lowering. So it's a bit of a tricky situation that we were in. So these ACC recommendations make me more confident about going to the PCSK9 inhibitor in that setting. I would love to learn from you all. I still am a little worried about the insurance criteria when I go with that strategy, because in my head, I don't know when I look at someone's insurance, okay, are they going to require it or not? And that could take some time to sort through. So that's the one thing, is getting that congruence between insurance criteria and what's being recommended in the guidelines or expert consensus statements. But the short answer is that I'm for a while, I've in some cases preferred to go to the PCSK9, and other factors like a high LPA level can also further justify that. But these ACC recommendations push me even more in that direction. But if somebody was starting with LDL levels where they're a bit higher, like in our case where they were 120s, that was even after ezetimibe. But if she had that 120s, then we added ezetimibe, I'd feel like, okay, we'll do that. I may accelerate the lipid testing, not wait 3 months per se, unless I thought it would definitely be needed, and then do it after 4 weeks and then go to the PCSK9 then. But I'm curious how you've been approaching as well.
Well, I when someone is further than 20%, I will try to go straight to PCSK9. But as you say, accelerate the process, because ezetimibe is, in most cases going to be approved and paid for, and so I encourage people in our division who really want to have handling these things and not referring to the lipid clinic to, please start PCSK9 or some of those other advanced therapies, to just, go ahead and step through it. If that's what you have to do, is add the ezetimibe and then move on from there. If in fact you get, back that denial. Heather, how do you approach that issue about step through therapy versus going right to something more definitive?
I completely agree as far as with both of you. Unfortunately, it's not sort of universal across payers. And so as part of that discussion, we say, listen, this will provide the most benefit as far as getting us to where we want to be. Again, if it's a large percentage, going right to PCSK9. But I say we have to also understand the insurance company may want us to do ezetimibe in the middle. And it as you highlighted, it's really keeping them in the loop, understanding the process, and so that they understand what we're trying to do and how to help them get to that goal and that journey. So, and then also, patient preference as far as where they want to start. I've had some patients say, I understand it may not get me there, but can I just try this other oral before I go to injectable? And I agree, escalating labs, seeing it, we set a time, labs are there, we know why the visit's going to be there. So both patient preference and, payer requirements, that really helps guide us. I also want to highlight just for the attendees as far as that, the newest document is an expert consensus, it's not the guidelines. And so going from statin to ezetimibe based upon the, the latest guidelines, that's still okay. We're just talking about how to really handle getting to that LDL, hopefully more expeditiously, but just recognizing that those are indeed, and that's an expert consensus pathway. So not yet as far as updated guidelines.
Yeah. I would say in terms of practical tips from clinic, some of the things that I've found, in case they're helpful to our audience, and welcome those from you all as well. There's a few of those that I think are impactful. The injection one you just referred to, it really helps, and everyone can get from the respective reps a demo pen. And when patients see that, it really moves them away from the notions they have of injectables, and just showing them it's a push of a button and you're on your way, and you don't have to think about it again for 2 weeks or 4 weeks, depending on how someone wants to do that. I find often I almost routinely get a reaction from patients who go, is less than what they were conjuring up in their mind. The second thing is that I sometimes we see patients who are worried about conflict of interest in the pharmaceutical companies and all of that, is I really highlight the genetics of experiments of nature of people who have, a loss of PCSK9 because the gene is broken, have demonstrated that they just, have a much lower incidence of heart attacks. Has nothing to do with drug therapy. And now we've found a way to give you that benefit some people were born with. And I find that impactful. And the last one is that in those first conversations, I try and set the stage for the patient to expect escalation of therapy, especially the one who's been resistant or we're trying to get around statin intolerances, to say, we're going to move on to higher doses, which, isn't done enough, and to a second agent. But that's to protect you, and that all those people having heart attacks and stents and bypass, wish they had done what we're going to do now to keep you from that or another event. And I find those helpful. One of the questions that comes up, Seth, that I'll ask you is, the role of CT scan for calcium, and is that helpful in terms of deciding who should be moving on to more aggressive therapy, or is it helpful in terms of payer coverage of now seeing a patient as having ASCVD or not?
Right. Yeah, I'd love to talk about calcium scores. Before I do that, I wanted to also just emphasize, I love what you and Heather both were bringing up around sort of setting expectations around that, often the need for combination therapy, and hey, here's what to expect. Jorge, that kind of connects with the conversation we've had in the past around when you're discharging after a heart attack, like have a plan laid out, okay, if the LDL does not get here, then you're going to do this, and have that really clearly laid out. And so as we lay that out with the patients, I think it helps in the shared decision-making process too, so that they've heard, okay, I might need a PCSK9, or I might need, and then they come back and they already have that seed planted, and then you can further build on the conversation. I think it's just really helpful, instead of it sort of seeming like, okay, here you need another drug. Okay, now you need another drug. And it just seems like every time we're trying to add a drug, really explain why and what the approach is and what the evidence and guidelines are up front, and then working through it over time. The calcium score is something that in the primary prevention setting can be used for the statin decision. This is recommended in the 2018 guidelines, that if the score comes, if you're in this 5 to 20% 10-year calculated risk group, if the score and the decision around the statin is uncertain, it can be part of the shared decision-making process. And if the score comes back 0, that's quite reassuring, and there can be a focus on lifestyle efforts. If the score is positive, that can help decide to go ahead and start statin therapy. And so early, the evidence was really largely focused around the statin decision based on having a positive score. But what's interesting is that there's accumulating evidence that really high coronary calcium scores can be indicative of having risk that's basically equivalent to someone who's in the secondary prevention setting, who's had an ASCVD event. In the past, I used to think of a CAC score of 100 and a Gadsden coronary artery calcium score of 100, really putting someone into this secondary prevention risk category. Although there's more recent data that it's really when you get up to over 1,000 that you have the type of risk that was seen in the Fourier trial. And so that threshold for calcium was introduced in this latest 2022 ACC consensus statement as a consideration for PCSK9 therapy. But I've used scores even lower than that as justification of non-obstructive coronary artery disease to justify more intensive treatment strategies.
Yeah, certainly in our clinic, when we do turn to them, when someone has calcium, and you can often find it on an old X-ray or an old CT scan in the abdomen, the aorta, don't have to send someone. I just start referring to the patient as ASCVD, and and I think that might affect payers. But Heather, we got a critical question here as we're closing up about when to start screening for FH, and what's your take on that?
So what I like as far as what Seth highlighted is really FH as far as number one, what is that LDL cholesterol level? I wish we could actually pull up the slides as far as the marker. The physical exam is also critical. It's important. And family history. So when we start hearing as far as also family history of premature coronary artery disease. So when we talk about LDLs, they're cut off as far as greater than 160, greater than 190. Really, the physical exam is important, but also really premature as far as premature atherosclerotic events. So the American Heart Association statement is really outstanding. I also want to highlight when we talk about risk, even beyond FH, as Seth was talking about with the CAC score, there's so many risk-enhancing factors that are now listed that even go beyond just that score. So I appreciate their case showing rheumatoid arthritis as one of the risk factors. It's often overlooked, and I think that's wonderful. And often when I talk about CAC, I say don't just look at the score, but also look at that percentile. Because then that percentile also talks about that higher risk patient. The score may be lower, but that percentile is huge. So be it FH, be it advanced coronary artery calcification, really high risk population. So thank you to the both of you.
Yeah, great points. It's funny because the guidelines and consensus statements, move on. Sometimes I find it's really helpful to hang on to some of the things highlighted in earlier statements that sort of get lost in the sauce, because those kinds of statements really do view the world as having moved on, but we know in practice that doesn't happen. And really, early guidelines said that every American, by the time they're 21, should know their lipid panel. And so I think that's one of the first ways you screen for FH is, if your patient's got an LDL greater than 190, there's a very good chance that they have FH. And interestingly, of course, as the evidence has came up, that someone who has an LDL under 190, but on the basis of a genetic issue, probably has increased risk. But so many interesting things to talk about. And we've had two fantastic presentations. I thank you both. I thank the audience for taking part in this webinar series, and encourage you to continue to look to NATF for resources and other materials, and even some of the prior events in this series. So thank you both. And I look forward to next time we cross paths and get to talk about these interesting issues again.
Thank you so much.
Thank you.